subject, and one of the key persons in India who are instrumental in instrumented gait analysis, and she'll take us through the principles and technique, and at the end she would also present some interesting cases and show us the importance of instrument gait analysis. So welcome Chasanal. Chasanal is consultant pediatric orthopedic surgeon in Mumbai at various hospitals, SRCC Mumbai, and she is everywhere. So welcome Chasanal. Thanks for your time, and the stage is all yours. Thank you.
Thank you, Maulin, and good morning, everyone. Okay. Just a second. I think it's asking me some password. I'm not sure why. It's Orthokids, right? Yeah, Sheenam?
Yes, ma'am.
Yeah, but so can you see the slides now?
Yes, ma'am.
Yeah, so we are going to talk about one of the important aspects in treating any patients, particularly with abnormal gait pattern or a deviated gait pattern. And today we'll focus more on cerebral palsy. So the gait analysis has an extended role for various etiologies. And typically when we see a child coming to the clinic, or when we walk in somewhere and we see a child sitting or walking, the first thing we notice is the child wheelchair bound? Does the child have crutches? Or what kind of functional status the child is? And with all this information, we try to label or put the child into a GMFCS, which gives us an idea of the functional status of the child. The functional status was important because all the treatment protocol, or how to design like dosage of surgery, or reach to a conclusion, or to reach to whatever decision making, it was important because the diagnostic matrix which came into use and was introduced by Professor John Davids, one of my mentors. And I think this is a very wonderful way to break down systematically and organize a child with CP so that we can reach a proper decision making and do the best we can and offer the best treatment and do justice for these kids. So the diagnostic matrix involves a very good and standardized physical examination. So the word standardized is very important. It's not just a simple physical examination, but a standardized, accompanied by radiology, whatever we need. And of course, the GMFCS and the FMS, followed by the gait pattern. So you see the gait pattern was one of the main important thing to describe or to reach the end of this diagnostic matrix. And why this functional status was important, because every time we do surgeries to improve the GMFCS level or the functional level of the child, and suppose the child at a particular age is GMFCS level 2 and he falls to level 3, that is the time probably an intervention is needed. Or that is the time when we have to really push the parents that now we need to do an intervention and not keep on focusing on conservative modes or wait for therapy much longer. So we don't let the GMFCS level fall. And also it is important because we divide the treatment in ambulatory children and non-ambulatory children. Our aims are totally different. So the ambulatory children, we have special and different aims why we would want to operate them. And most important is to correct their gait. So the gait correction surgery is one of the aims why we would want to treat an ambulatory child with CP. And that's why it's important to know the gait analysis. So I was very fortunate to learn this gait analysis with father of the motion analysis, that is Professor Jim Gage, more than a decade ago when I was training. And he, way back in 1993, wrote his first paper on gait analysis. And then he had mentioned that it is an essential tool in the treatment of cerebral palsy. Of course, he mentioned it's an essential tool, but we don't, let me highlight that it is a very expensive setup. It is not easy. The learning curve is very, very long and steep, I should say. And yes, it takes time. It's not that one day we attend a gait thing or 2 days ka gait course, we do it at US or some other country and we'll master it. No, it has to be used over the years with every patient of CP. And then only we understand that how and what happens with each child and what more can be offered. So this is what he mentioned. And this word is something I really like, because he said that the entire treatment had changed dramatically with the advent of gait analysis in cerebral palsy. And you see how it changes. So this is what we normally see a child walking in the clinic, maybe with the help of parents or without the parents. And this is a whole lot of information we get in gait analysis, right from each of the joint movements to the joint forces, a very detailed video evaluation and a good analysis which will remain with us to review. And this is like performed couple of trials. So at least 10 trials are done before we reach a report. Here in a busy OPD, we might probably give 15 seconds to or 30 seconds to just look at the child. Maybe the child is sleepy, cranky, there are some mood disturbances, that day the child is not feeling well. And it might just obscure or give us a false feeling of some different pattern or not help us pick up the small intricacies of gait. So that's how he said that it had changed dramatically. The whole thing changed. And way back then, Winter Green, they all classified the gait patterns into sagittal gait patterns. And these were clinical gait patterns as well as gait patterns which could be used in a lab. And they just looked at patients from the side and they classified them as group 1, 2, 3, and 4, depending on what movement the ankle, knee, and the hip were. But then they had some times and some situations where they had non-classifiable options. And then further, more and more detailed studies were done. And this classification was much more spread out, or maybe explained much more in detail by Professor Graham and Jill Roda. And then we know that now we have two different clinical gait patterns for hemiplegics and for diplegics. So let's see for hemiplegics. So if you look at this one, the type 1, that is the foot drop pattern, where there is probably a spasticity in the gastroc, but there is no fixed equinus. And there is also an weakness of tibialis anterior. So the child walks with a foot drop pattern, and there is maybe a slapping of foot or difficulty in clearance of that particular lower limb. And then the type 2, where there was just fixed equinus at the ankle, was further divided into 2A and 2B. So 2A is an early toe walker where just the equinus has happened. We'll not call them toe walker because it's a hemi. So yeah, they are walking on toe, but we don't call it an equinus gait. We'll call it a type 2A gait, where the ankle is in equinus, the knee is straight at initial contact, at mid stance, and at terminal stance, and the hip is also in neutral position. Now there's a 2B where secondary to the spasticity, now the child has gone into compensation and there is a recurvatum at the knee. So we usually come across this 2B. Before that, the parents are doing therapy or they're wearing an AFO, and then they come to us when things start getting bad. Yeah, so this is the type 2B. 3 is where ankle is in equinus, knee is flexed, and also the hip is flexed. The 4 is also again the ankle equinus, knee flexed, and the hip flexed. Now here, additional thing is we look this patient from front, that is the coronal plane, and we see that the limb is also adducted, and probably the psoas and the adductors are involved here. So that's how we label a hemiplegic always as type 1, type 2, type 3, and type 4. And similarly for the diplegics, when there is only equinus and knee straight, we call it a true equinus gait. And when there's an equinus with knee flexion, it's a jump knee gait. When there is, now this is an important thing, and this can easily be picked up only with an instrumented gait analysis and needs a lot of experience to pick this up in clinical setup. The apparent equinus gait, where it seems like there is an equinus, but actually it's the tibia which has moved forward over the ankle, giving us a false feeling of equinus. The heel is up secondary to the flexion contracture of the knee. And that's why it's called apparent equinus. It's not a true equinus. And here we don't treat the gas stroke. If we treat the gas stroke here, the child will become non-ambulatory, the child will deteriorate, and we can maybe induce an iatrogenic crouch. So that's why the apparent equinus is a very important and a very tough classification in terms of gait pattern. And the last pattern is the crouch pattern, which we come across very common, where there's a dorsiflexion of the ankle. So here, the angle between the tibia and the foot will be beyond the zero or neutral. So it's in dorsiflexion. It's no more in plantar flexion or neutral. We don't see the heel up. We see flexion at the knee and there's flexion at the hip. Okay, so now I'm going to show a couple of patterns and you'll have to just let me know quickly what it is. So this is a right hemiplegic child, and what type of pattern do you all think it is? You can just type in the chat box and you can see that. So right hemiplegic, and you have to let me know if it's a type 1, type 2, type 2A, B. Okay, so far. Yeah, so let me know if anyone.
It's a type 1 gait, ma'am, because
it's type 1 hemiplegic. Yeah. So it's a type 1 hemiplegic. You see the child has difficulty in clearing the foot. If you have a look here. So it's a type 1 hemiplegic gait, and there is a sudden slapping of foot and he tries to clear the foot. So this is type 1 hemi. Now this one. So now he's a diplegic. We know the knees are in flexion. So we look at the ankle and see if the ankle is in equinus. So if the ankle is in equinus, it becomes a jump gait. And if the ankle is in neutral position, it becomes an apparent equinus. And if it's in dorsiflexion, it is a crouch gait. So what do you think is this one?
Jump knee.
Yeah, it's a jump gait. Yeah. So it is a jump gait, and with the weight, the child has now slightly progressed with a mid-foot break, and he will progress towards a crouch now. So jump gait remains for a short while in very thin-built kids. Now this one. Again, right hemi. So the ankle is in equinus. And what do you think is happening at the knee? So the knee remains straight most of the times, and it's just the ankle which is going in equinus.
Type 2.
Type 2. It's a type 2 gait, and it's a type 2A. Okay. Now this one. So he's a diplegic.
It's crouch gait.
It's a crouch gait, yeah. So you see that the ankle is now in dorsiflexion, the knee are flexed, and also the hips are flexed. Okay. Yeah, so anyone, this one. Yeah, so I didn't talk about this. This is a stiff knee gait. Stiff knee gait is a gait pattern which is not classified in these gait patterns. It is secondary to the rectus spasticity, where there's a decreased flexion of the knee in swing phase. So the knee is unable to kind of clear or progress ahead during the swing phase, and it remains straight. And secondly, it can go into a recurvatum because of severe spasticity. Secondary to the rectus spasticity, you will see that the pelvis is anteriorly tilted. Unlike other children, this pelvis is not neutral, it is more anteriorly. And a similar pattern can be seen in over-lengthened hamstrings or in stiff knee gait. Okay, so this is a stiff knee gait. Okay, so now let's look at this. He's a right hemi. So now he's grown up. So they don't tend to walk in one gait pattern, and as with age and as the spasticity kind of wanes or comes back more, the patterns change. So let's look from the coronal plane. So he's not adducted, but he's internally rotated. If you see, the foot is internally rotated. The patella seems to be slightly internal rotated. There's a rotational problem. There's not adduction at the hip. So we don't label him as type 4 hemiplegic. He's more of a type 2, type 2 hemiplegic, but also still I'll put him in a non-classifiable option. And what cases we saw before, they were very classic cases, which can be grossly labeled as what type of gait. But most commonly, we'll always come across children who will not have a classifiable gait. And that's where the 3D gait analysis works. And that's how it helps. Because now we can label, we can explain what is happening at both the limbs. And no more we would call a child that this child has a jump gait or a crouch gait. Now, if you look at this child, he's almost 6-year-old. He's a diplegic. If you see the right side, he still continues to walk as a jump pattern, but the left side, there has been a midfoot break, and now there is a neutral position. So I can't put him as a jump gait, nor can I label him in a crouch. So here the 3D gait analysis gives us much more better options. And instead of labeling them, we describe each lower limb separately and not put it in one particular category. So we would say he's a diplegic, but he's an asymmetric diplegic. So not always the diplegics are symmetric. Always one side may be slightly more involved than the other side. So this is an asymmetric diplegic. And there have been effects of midfoot break already on the left side. So he was walking with a jump, and eventually, because of constantly the jump gait, you'll see the kids kind of put so much pressure and they just run on it. So the midfoot joint gets affected the most, and there's a midfoot break, further causing lever arm problems. So that's how the gait analysis comes into picture, because now we know that we have to see much more things rather than just simple joint movements. What are they happening? So the basic 2D analysis or a simple video analysis or gait analysis is recorded with a camera or a mobile camera on a tripod or a gimbal. While the videos in the gait lab, they are recorded with a specific cameras, and it's an instrumented gait lab. I'll show you that. And of course, this helps us to understand the key events in gait cycle. So we will know what is happening at initial response, what is initial contact or loading response, mid stance. But in the gait report, we'll get much more things along with what we got here in kinematics, that is the joint motion. We will get the kinetics and also the temporospatial data. Now, temporospatial data like the cadence, the stride length, step length, all this is very difficult to calculate looking at patients in the OPD, which will be very easily available with a gait analysis lab. So we can use this video with a particular scoring system and score our gait with the help of Edinburgh Visual Gait Score, which is the commonest gait score done in absence of a gait lab, or even in presence it can be used. And of course, the one which we see a basic video recording is subjective and it is very time consuming. While the 3D gait analysis lab will give us more better scores in terms of gait profile score or motion analysis profile, and it's a much more detailed study. Now here, again, we use the gait analysis only in ambulatory children, and the gait analysis, 3D gait analysis works very well when the clinical findings don't match the gait findings. So suppose the child walks with a flexed knee, but when the child lies down, there is no flexion of the knee. So if there's no flexion, what are we going to correct? So at times what we see dynamically may not be present when the child is lying supine statically. So that's how there is a discrepancy in our clinical findings as well as gait findings. And that's when this comes into picture. Again, there's combination of gait patterns. There could be a mixed stiff knee along with crowds, or like we saw asymmetric cases. All those cases are very good candidates and the ones which should undergo gait analysis. And of course, the pelvic tilts, which are not explanatory on a clinical gait pattern, because we can't see if the pelvis is anterior or posterior. And a lot of surgical making would be based on that. So usually a gait lab is a kind of a hallway where the cameras are mounted on the walls. And these are special cameras which pick up this reflective markers. So each lab has a different system. There are various systems. It's just like using a smartphone. So the Gait Lab is also similar to using a smartphone, where you have a variety of different companies offering different softwares and different scoring systems and lot of additional information. So the markers are put, they are standardized, and then this frame is removed after it is made sure that the markers are put with the least error. And then the child walks around. There's a force plate which is hidden in the floor, which picks up the heel strike. And this gives us what we call the kinetics, that is the ground reaction force of what is happening. And what you see, the lines marked on the pelvis, the femur, the tibial shank, and the foot, that will give us the kinematics. So what we get is the kinematics is basically the joint movements and the dynamic movements. The kinetics will be the moment, that is the power and force which is being generated during the gait walk. And additionally, the temporospatial parameters, like I mentioned, we get in a gait report as well. So it helps us to pick whatever there's a gait deviation, even smallest deviation from the normal pattern, the graph will quickly show. And additionally, of course, it makes our decision making much more stronger and confident, and it helps us to quantify the results of our intervention. So let's have a look at each of it quickly. So like I mentioned, the kinematic is just the study. So the way the child is walking is just noted, and that is the kinematic. We are not defining, we are not classifying, it's just kind of what is happening at each joint. And then we see that at a particular speed and in a particular time, what distance it is being covered, which give us the temporospatial parameters. Okay. Yeah, and the kinetic is every time in the stance, when the heel strikes the force plate, we would get that what amount of forces are being generated. So in an equinus, when the child walks in an equinus, the ankle forces are not generated the way they should be. So it gives us an idea how fixed or how dynamic the equinus is and how much problem is happening at that particular joint level. So this is how typically what a gait report looks like. Okay, so before we go ahead, we quickly revise the terminology so that you understand when I talk about it. So the gait cycle is divided into a stance phase and a swing phase. And the stance phase is where the foot is in touch with the ground. The swing is when the foot is off the ground. And this is, the stance is like 60 to 70% and swing is 30%. It differs in children with CP. So the child with stiff knee will have a stance phase of 70 and maybe stiff swing phase of 20 only. And it would differ. So you will see how gait analysis helps us pick that. And so what we have, the common terms which we used to use as heel strike is now called as initial contact. We no more use the word heel strike because most of the times our children are doing toe strike. All the CP kids, never they have a heel strike. So this terminology is no more used. What we use is initial contact, loading response, mid stance, terminal stance. And the swing is further pre-swing, mid-swing and terminal swing. Okay. So now if you look at this report, so suppose a child comes to you with this particular report, how and what are you supposed to interpret is what we talk about today, rather than like just being embarrassed or not knowing anything to talk about. So if you look at this, the gait report, the top horizontal 3 graphs, they are for pelvis, then the next 3 are for the hip, then the next are for the knee joint, and the last 3 are for the ankle and foot. So horizontally, they define the segments of the body, and vertically, they are the 3 planes of the body. So this is the sagittal plane. When you look at the patient from side, these graphs are generated. When you look from front, that is the coronal plane, these graphs are seen. And this is the transverse plane, as if you are on the top and watching the patient from the top. So this is something which we can never get from a clinical gait analysis again. And the red and the blue lines you see, so this is the stance phase. So this vertical lines again divide it in stance, and this is the swing. And the right here is red and the blue is the left. And each labs have their different right and left. And you will always see that each of the reports, they give it on the top, which is the right and which is the left. The green is the normal. So if suppose any normal person would be walking, his graphs would be at the green level. So whatever green lines you are seeing is the normative, and whatever red you are seeing is the right side, and the blue is the left side. So it's very easy. Once you know that what has to be seen, it's very easy to understand what is deviating from its normal. So if you look at this pelvis, it is written here, what is posterior, anterior, flexion, extension. So let's look at just this sagittal one quickly. So the normal pelvis tilt is this one. And what is happening here with the patient is a slight posterior pelvic tilt. Again, in the hip, we see if the hip is flexed or if the hip is going in hyperextension. So the normal is the green, and the red and blue lines are typically following the green line. So the hip is still okay. Now we see a lot of deviation in the knee here. So you see the green is here. So the initial contact, the loading response, and the terminal stance, the knees are almost in extension. And then in the swing, it goes in flexion because it has to clear and move ahead. So you will see both the knees, they are in around 40 to 50 degrees of flexion throughout the stance and also in the swing. So this is probably someone who's walking with a flexed knee. Yeah. So that's how you pick that the knees are in flexion, and we need to correct it. So when this child is operated and a repeat gait analysis is done, these graphs will fall along with the green line here. And similarly for the ankle, it has to be a heel strike followed by a slight clearance. And then again in swing, it goes into little dorsiflexion so that it can be cleared and we are ready for the next initial contact, which is a heel strike. So that's how the report is seen. And it's very simple. I mean, it's nothing much. Of course, it needs a lot of regularly watching the gait reports. So now for this, both the kids, you see both the kids have a slight equinovarus. The child on the left side has much more equinovarus, and the right side is a severe equinovarus. So if you see this child here, you will see that the ankle, they are not following the green, they are into equinus. So the left foot particularly is going in equinus, which probably is not visible. So now post equinus, she's gone in varus. So we think it's just a varus and it will correct. But no, the gait lab has helped us to pick that no, there is also an equinus. So it's not just a tendon transfer or a tibialis posterior lengthening which will help here, but there has to be a gastrosoleus recession also required to treat that. Similarly, this child, if you see, there's a severe equinovarus. Now she is heavy child compared to this, although the age groups are similar. But the equinus, look at the amount of the equinus, the red line here. It's so much away from the green. So the deviation is so much. Understand that here the deviation is so less, but there are demanding parents who want perfect gait pattern, and we should act quickly before this sets in and becomes worse. So we know that there is an equinus already and a weakness. So probably there needs to be strengthening or a hinge or what needs to be given. Here, of course, we need a surgical intervention. So that's how this is going to help us understand and pick up the subtle problems as well. Now in a child with crouch, if the post-pelvic tilt is posterior, like way beyond the normal line, then of course we divide it into two stages. First stage probably would be a hamstring lengthening, followed by reducing the knee flexion deformity, so that when we do the definitive flexion femur osteotomy, a small part of the femur will have to be removed during shortening. And hence, based on this, we can plan in a young child if simple hamstring lengthening and transfer will help, or only a hamstring lengthening is okay, or do we need to do a bony surgery right away. So this graph helps us to define a dosage of surgery in varying amounts of crouch. You will always see that there are some crouch who walk with a mild crouch, and then there is somebody who's already sinking in the ground. So all the crouches vary, and then we have to just work on looking at the other joints and the other graphs, what and how the dosage of the surgery needs to be planned. Again, now if you see, this is a mild crouch. So when he walks, there is a knee flexion there. But when I checked him in the supine position, there was no knee flexion deformity. So now this is a child where Botox will help. And we know what is happening here. And again, with his aid, we would still think that if a lengthening is to be done or a botulinum toxin injection needs to be done. And based on these two graphs, it will be the decision making between doing a chemodenervation or a muscle or a myofascial lengthening in that case. So although the Gait reports are not a ready to operate prescription, they will never come like, it's not like, it is not an artificial, it is a kind of artificial intelligence, but it will not tell us now the patient has walked and you need to do this and this. No, we have to correlate a lot of things before we make a surgical decision. And Gait analysis is just one small part of it. The more important is the physical examination and the functional status, the radiological studies which help us to kind of confirm our findings, and of course the gait studies which will help us make the gait better. So like the previous child, he was walking with knee flexion, but lying down is good. So what we have to make, we don't have to correct his knee FFD, but we have to correct his gait pattern. So every time the goals will be different. Similarly, when the child is operated, we always say that the child is walking good, or wow, the child is walking so nice. But how do we quantify the results? How do we know that the child has really done good? And in the previous time, Professor Gates said that it is always we label kids as they are doing better, good, or sometimes we say they are walking differently. So he said we put these kids post-operatively in this, while with the advent of Gait analysis, we started quantifying them in terms of numbers and the deviation index, and how the gait profile score helps us to kind of not only quantify the gaits, but also use this data for research purpose and for knowing better or evaluating our own results. So this is how a gait profile score looks like. And it talks about each of the segments again. That is, this is the total score. And then there is pelvis, hip, knee, ankle again on each of the side. And we see that pre and post, what is happening and how much minimal clinical MCID, that is the minimal clinical important difference, has happened. And that helps us to know how much improvement has happened. Now, there are various studies so far who talk about how gait analysis has changed the management. So there have been studies where they said that they post getting a gait lab, there was reduction in the number of procedures. Also, they said that some of them said they added additional procedures. What I also felt that there was reduction in procedures at hip level and more procedures at different knee or different types. I'll talk about them. And very recently, Professor Unnis mentioned that it is a wonderful tool. Problem is there is a lot of reluctance in using this. So people have a lot of reluctance because one, it's complex, second, expensive, and again, it is also time consuming. But let's look at the brighter side, that it is for the better decision making. It helps us to provide the best and correct interventions. And also it helps us in creating good evidence for whatever we are doing. It's not, so earlier people used to do TA lengthening. They never realized that that was causing crowds. But over a period of time, it was taught to us that we are supposed to do zone 2 level gastrosoleus recession, which is the safest zone. And that's how we created an evidence. So having a gait lab or doing a gait analysis is like you own an expensive car, but you don't go on a corner garage to get it repaired. We take it to a place where there is much more better systems to analyze. And with all the more facilities we have nowadays, we want to have the best for everything. So same is for kids with CP. Their parents want to have the best thing so that they walk the best. And with the advent of gait analysis, what we used to earlier do was a lot of rectus femoris transfers, which eventually changed. And now we do a very small and a very mini procedure of distal rectus lengthening. We no more lengthen rectus at the hip levels. We lengthen rectus at the knee levels because they work more at knee rather than at hip. And also, this was a very tedious and a time-consuming procedure, again, doing with other procedures. And this has shown very good results in a long-term study of 10-year follow-up with gait analysis. Also, earlier we used to perform a lot of psoas releases. So even during my training, I learned doing a lot of over-the-brim psoas lengthening. which over the period has changed. So with gait analysis, we pick up the smallest knee flexion problems, and according to that, we don't do psoas and rectus lengthening anymore. And the dosage of surgery has totally changed. What earlier times was called the birthday syndrome or birthday surgeries, and then the single event multi-level surgery has changed to a newer terminology, that is dosage of surgery. So the dose is divided for each muscle and dose is divided for each joint. And this is how the change in surgeries have happened. Instead of releasing all the psoas, so if you see, still in some places you would see patients who go to a typical CAM setting have 3-level incisions, one for the psoas adductor, then for the hamstring, and then for the gastro. This is a very old and absolute technique which was being performed and which mimicked more of polio surgeries. And then we shifted to semi-T transfers and hamstring lengthening and gastrosoleus session. Now we define the dosage of surgeries, which is a combination of soft tissue as well as bony procedures, and they are done in a go. So just like a single event multi-level surgery, the dosage has a lot of other things to it, and it is divided based on each extremity. So this is a very nice, again, a recent study, and this says that it could help us to prevent inappropriate surgical decisions. And they said that they had made surgical interventions they would make changes in the surgical interventions more for gastro and rectus. So like I mentioned, yes, rectus surgeries have changed, psoas surgeries have changed. We no more do the adductor tenotomies for ambulatory kids. It is even thought there's a wonderful paper from Australia which talks about this, and we no more do the adductor tenotomies or the neurectomies which was being done in the past. So there has been a drastic change, and there are numerous and many papers which talk about this. So this is all about the good part or the brighter side, but there are errors, there are problems with the gait labs also. One is we can't do small kids, and there is difficulty in doing analysis for obese children. Again, severe scissoring and crouch is difficult to get this very good gait graphs. And again, there are a lot of software as well as hardware problems. So if we look at it, just to summarize, preoperatively, it's a great tool. It helps us pick subtle problems as well as complex problems. Although it's not a prescription, but we will reach to a dosage of surgery. And then if we correlate it and put it in our diagnostic matrix, we can do a very good job, and we can quantify that job and use it as what we have done, as use it for research purpose. And there are limitations, like I mentioned, that like every AI or everything which is related to technology has its own. But yes, it is a very good tool and it gives us a lot of information. So that's about gait in short, quickly. And last month, we had a very good webinar about normal gait pattern, which is uploaded on the OrthoTV, and it was given by Professor Dhiren Ganjwala sir. So I would request that for the normal gait pattern and the normal gait graphs, you can just refer to that particular talk, because that itself is a 45-minute talk. So with this, we are going to quickly do one case, and each one has to participate quickly in this. And there are actually two cases. This is a very simple one, and then we do one complex case. Okay. So this is a 7-year-old child, and he's a hemiplegic. You see,
we are not able to see your
We're
screen.
not able to see. Just a second. Good, you told me that. Now?
Yes, ma'am. Now it's
Yeah.
good.
So this is a 7-year-old kid, and you see he's a right hemiplegic. Okay. And so the parents had concerns that he's walking on toes. And this was the birth history, which was relevant. The brain MRI showed encephalomyelitic changes, and he's on therapy so far, and nothing has been done. He is GMFCS1, and a quick evaluation that how the diagnostic matrix works. So I've done a quick evaluation. One is to get the core strength. Second, to quickly analyze what's happening with the gracilis, the adductors and the hams. So a combined hip abduction angle. And what is with the knee, if there is a flex knee deformity, knee FFD or not. So there is no knee FFD here, and even the functional popliteal angle is 0. So what we do, the R1 is usually with the hip flexed at 90 degrees. So the functional popliteal angle is important because we don't walk with the hip at 90 degrees flexion. We walk with hips flexed at 30 degrees flexion. That's why functionally what is happening has to be seen at 30 degrees. And if this is flexed, then of course there is a more than tone, there is a length issue. And then we'll do the R1, R2. So this is the R1 and R2, which is around 40 and 30. And the popliteal shift is almost 0 with 30 degrees of further R1. So the core is important because only if the core is good, we know that the intervention is going to help. And apart from that, so I've seen that he stands with a knee flexed. We saw in the first picture. So that's why I focused more on the knee FFD and not put pictures of the hip here. And so what's more happening at the knee? Is there an extension lag? And also if there's a rectus involvement or not. So this is in quick about the, okay. And with the ankle, if you see, now the R1 is fixed in minus 30 degrees plantar flexion. The R2 is again same, it didn't change. Only at R3 after flexing, there was a slight 10-degree change in the equinus pattern here. So that's how it's with the ankle. And this is in short, the clinical evaluation. And we are going to see if there is any torsional problem. So is there a femur increased anteversion? And how is the thigh foot angle? And what is the pressure or the contact when the child walks or stands typically? Okay, and what is the selective motor control? So it doesn't matter much in hemis, but of course it matters in the diplegic. Yeah, so anyone, what type of clinical gait it is? Type 2 or type 3? So is the knee straight at any time? If the knee is flexed throughout, then it becomes a type 3. If the knee is straight to begin with and in mid stance, then it's a type 2. If we can't fit it in there, we don't need to do that. We can just write the child is GMFCS1, walks with ankle in equinus. The knee is flexed throughout the stance and swing, and the hip seems to be in neutral ROM. Okay, so that's how we just describe it when we see the child walking. On seeing the child in the frontal plane, there is a slight circumduction while clearance. There is no adduction. You see, there is a pelvis hitchhike. If you see, the right side pelvis is slightly on a higher level as compared to the left. And that is because of the equinus. It is not a pelvic obliquity as such. And let's, yeah, so I've put him as type 2 hemiplegic. And this is the 2D, the Edinburgh Visual Gait Score. And these are the graphs. So this is how the graphs are. So let's look at this. So now you have been able to understand that we are looking at the sagittal video. So we will just see the sagittal graphs. If we had a frontal video again with us, we would see both the graphs together. And then we correlate it with the transverse plane, which we'll see the next patient. So here, what do you expect with the pelvic tilt? So hemiplegics will not have a lot of anterior or posterior pelvic tilt. They will have something like this, an alternate thing, because the right is involved more and the left is not. So they are still away from the normal. You see, there's an alternate protraction and retraction happening there. So alternately, there is a protraction. So this is the stance phase. This is the swing phase. And what is happening at the hip and knee? It is the hip is typically good. If you see the right side, there is a slight decreased extension. So because of this equinus, now this is compensatory. We saw in the clinical evaluation that there is no hip FFD. So we ignore this because we already know that no, it's not the real hip flexion deformity here. He's walking with a hip flexion because of the severe equinus here. And again, what's happening at the knee joint? Yes, so there is a flexion at the knee. Although we didn't see a knee FFD, but yes, the hamstring R1, R2 were little on the higher side. And we see that even the opposite knee is going into flexion. So you see not only the affected, but the opposite. because it's in a process to quickly clear the foot and get off the weight of the affected foot. So just because it's difficult to walk with so much equinus, the child will want to quickly change the limbs and take off the weight of this affected leg. And that's how the other knee goes into slight flexion. And of course, you see this side, the right side is so much into equinus, while the right side is, while the left side is doing good, it is following the normal gait graphs. So that's how it is. And so these are the features, and we correlate it with whatever clinical findings we have got. And I would, from this, suggest that there is probably just a right gastrosoleus contracture. The hamstring is good, and the R1, R2 of the hamstring was also good. So we just probably focus on the gastro and do a simple gastrosoleus recession in this child. Also, if you see this additional force or the graph data will show us what is happening. So this is the kinetic data. So it is going to show us if the ankle power is being generated or not, or is the ankle is going in eversion, inversion, what is the power and force. And if you see here, the dorsiflexion moment is reduced so much. I mean, there is hardly any force. The right side is flat line. So it is not creating the amount of force it has to do. And that's how the gaits are energy consuming gaits. So now the last one is quick. So we have 10 minutes. We're going to do one last case, which you all have to tell me the findings, and then only we are going to talk about it. So last one is a difficult case. It is something which we would not be able to actually pick up any point of time without a gait analysis. I mean, such cases would always need a gait analysis. Can you see the PowerPoint now?
Yes, ma'am.
Yeah. Okay. So this is a 17-year-old child. You see, he's quite heavy, huge child, and a diplegic child. He has been given injection botulinum toxin in the past, and he had undergone a hamstring lengthening 2 years ago. So in spite of all this, look at the amount of crouch he still has, and look at how he walks. So he's a GMFCS3, we would say, because he's using support to walk. And just see how slow the gait pattern is. Just observe. We don't have to reach to some conclusions very quickly. So he holds the hand high to maintain a balance. There's a high guard. And we see that the right side is affected much more as compared to the left. And he tries to balance a lot of his weight while trying to advance the limb. And if we look at the sagittal pattern, the ankles are in dorsiflexion, both. And the left one is, of course, everted also outwards, the ankle. And the knee is in flexion throughout, and there's flexion at the hip joint as well. So this is a crouch gait, of course, but there is a lot of other things which we need to understand and pick here in terms of where the patella is facing, where the ankles are going, and what is happening at the pelvis again. So he has undergone pelvis hamstring lengthening. So we know that probably the hamstring was probably more backward. The pelvis was backward tilt or posterior tilt, and now it has become neutral. So now it's a good candidate to just do a femur osteotomy and not again undergo a hamstring lengthening problem. So looking at this video, can you tell me if his pelvis is forward tilted, posterior, neutral, or you all think it's difficult to answer? Now he's a thin built child, but still, like, quickly, what does everyone feel? Is it? So probably it is neutral to me. I think it's a neutral here. Anyone else? You're neutral, yeah. So any other answers? Okay. we're going to see what the lab is showing us. So this is the normative area, and this is what the each side of the pelvis would represent. So yes, it is almost following the normal thing. It is not too much posterior or forward. So sometimes it's easy to pick, not always it would be like that. Again, do you think there's a flexion of hips here? Yes, no, or you think it's difficult to answer?
Yes.
Yes, there is a flexion. Okay. So we are going to see what's happening in the graphs here. So there is a hip flexion. You see, there's so much flexion which we actually can't pick. Part of which could be compensatory, secondary to the knee flexion. And we cross-check these findings also based on our clinical findings. So we know what is happening here. Of course, the knee is in severe flexion. I'm not going to ask you all this question because it is like anyone would pick this up. And if you look at this graph, just look at the amount of flexion it's having at the knee joint. So this is in the sagittal of the pelvis, hip and knee. And let's look at some other things here. What is happening with the ankle? So let's see the left side only. I think it's in neutral, dorsiflexion, it's in equinus, or is there an apparent equinus?
Apparent equinus.
Okay. Anyone more? So let's see what's happening. So the ankles are in dorsiflexion. So if you just look at them here, so the angle between the tibia and the foot will help us understand if it's a dorsiflexion or what is happening in fact. So if this is neutral or below here and the heel is just going up, and at initial contact, if some point of time the heel touches down, then it becomes an apparent equinus. And again, here we see it's more of dorsiflexion. Both of these are in dorsiflexion. Of course, both of these are in dorsiflexion. So that's how the apparent and true and the dorsiflexion are much more better picked up on gait graphs as compared to the clinical findings. So everyone can like kind of argue or have their own opinion because it's very subjective what we see and feel. But this is in terms of based on the lab and the marker systems, it is going to let us know the foot, what is it in correlation with the tibia, and how the tibia is with the femur, and how the pelvis and femur are correlated, and how is the pelvis in terms of the lab. So that's how we come to know that. So these are the sagittal graphs, and now these are the coronal graphs. So if we look at this one, now we need to have a coronal video if we want to see the second set of graphs in our report. So we see the pelvic obliquity, yes, it is kind of not too much of obliquity in the coronal plane, but yes, there is a hip adduction, abduction, which is happening. So you see the hips are constantly adducted, while they should have been abducting at one point somewhere in the swing, they are not. And if you see, both the legs have different stance and swing phases. So you see one of the leg swings more, one of the leg has more movements, and of course, everywhere there are different stance and swings for each of them. So this vertical lines are helping us to understand that. So the hips are adducted. The knees also adducted. Again, the left is much more adducted as compared to the right is much more adducted as compared to the left. You see the patella is facing inwards, and there is a lot of adduction and internal rotation happening. So now we know that the patella is going inwards, the legs, the femurs are rotating inwards, and the tibia are going externally. So this is a malalignment when the femurs are in and the tibia is outward. And now we need the third plane, that is the rotational plane evaluation of the same patient in the gait report. And let's look at that. So this is the rotational plane. So now this is difficult to judge on the videos, like I mentioned, because the transverse plane are movements which you would be seeing, probably imagine seeing it from the patient on the top, that if the pelvis is being internally rotated or externally, is the hip internal or external, and these are very difficult, plus difficult to correlate, and there is a lot of compensation happening here, you will see in this patient. And at such times, a rotational CT profile helps us much more to ascertain our findings on the gait here. So if you look at this, let's start from the foot. that the right side is externally rotated. Of course, we can see that it's too much of external. And the left is probably near the neutral, but yes, it is still external, but not as much as the right side. So it's still 30 and this is like 75 somewhere around. So there's a lot of external rotation in terms of the FPA. And what's happening at the knee? So the tibia is following the foot. So the foot and tibia are following each other. So if the foot are outward, the tibia torsion is also external. And that's what is here. And now we look at the hip. So are they in like aligning with each other or something else is happening at the hip here? So we see that the right side is external. So let's look at only the right side now. The right foot is external, the right tibia is external, and the right hip is also external. But if you see the pelvis, it is internal. So although the hip is going externally, the pelvis is trying to become internal inward on the transverse rotation. Because with more of external movement of the hip will get uncovered from the acetabulum. And that's how the body or the pelvis works, so that it can kind of cover, uncover, plus balance the hip and knee below. So that's how it is going to work. And we see so far everything was right. And suddenly here things have flipped. So here we will not go around and correct so we have to be very cautious in doing the hip the femoral derotations in such case, and think about more in terms of tibial derotation osteotomies whenever we plan a correction. So now additional to this, so we'll skip this because these are very difficult to answer. Here all the answers are going to be difficult to answer. So, and I explained you all this, what is happening, because now we are short of time as well. So let's skip to the last final slides. Yeah, so now we know that he's having the external foot progression angle, the tibias are external, but the hip, we had seen that the hip were also following the same procedure. So we clinically see what is happening. So clinically the femur looks good, prone, and what's happening with the thigh foot angle also, we are going to quickly see. Actually, with the gait analysis, there is so much to see that probably sometimes it feels exhausting, but it gives us a lot of information and we can probably divide the treatment very well. So you see so much of foot progression angle, the feet are externally rotated, and what's happening with the heel, if there's a valgus or, okay, and that's the foot pressure. I think, yeah, and that's the thigh foot angle. So we saw that the right side has an intorsion, the right is much more externally rotated. And that's what we had seen on the gait also. The right was much more as compared to the left. So that's the rotational profile on CT. And you see that the femurs, they are around 14 on the right and 22. So the left has a slightly increased femoral version. So we expect that the internal rotation should be more in terms of walking, but we saw it was fine. It was following, and the tibia, of course, there is a lot of torsional issues. So we correlate the gait and our CT again and see what is happening. So of course, there is a proper correlation. We see that the right side, there was a lot of torsion. Of course, here also right side, the foot is outward, the tibia is in external rotation, and the hip is almost fine. I mean, the hip is doing good, except for the opposite hip, which is slightly more internal, which we also saw that the angle was slightly more here, 22. But it's fine. This is borderline. I mean, this can be corrected while doing a crouch correction. But here with this information, now we know that we have to divide this patient in terms of 2-stage treatments. And first do the crouch correction, that is correct the knee flexion deformity. We also know that although the supine flexion deformity is much less, but he walks with so much of flexion. So there is a quadriceps insufficiency. And we know that there is a patella alta from the X-ray. So of course, a FEO, that is a femoral extension osteotomy with a patella tendon advancement, will take care of all these problems. And also it will correct the secondary lever arm problems at the ankle. And in the same time, rotational problem can be corrected on the left side while doing the crouch correction. And the second stage, I'll do a tibial derotation osteotomy. So that's how I planned this child. So initially I had undergone ham lengthening already 2 years ago somewhere. And I've done a crouch correction with the FU and PTA, and the left side I did the derotation. And after a year or so, when I removed the implant, I did the tibia derotation again for him. So this is the pre, and this is around, I think, 2.5 or 3 years of follow-up now, 3.5 more. So you see, he's still, so we haven't been able to change his GMFCS level. So now, like we discussed in the past, we do surgeries to change the GMFCS level. So on paper, he will be like 3 has turned to 3 only. There has been no change. So somebody just reading the paper will think all these surgeries have not made any change in his life. But when we look at the gait reports or a detailed evaluation, we know that a lot of things have changed. Now he has so much of stability, he has so much of control over himself, although he still needs support, but it is still so good. I mean, look at the cane here, how it's just wobbly, and look at it here. It is so much more better stable. The foot, I have done nothing, but just look at the beauty of just correcting the knee, how the feet have become good. And the tibia, I did a derotation here, supramalleolar osteotomy, and now the foot progression angles are much more better. The left side looks so bad. I mean, looking at this, we would probably want to correct both the tibias and probably make a very vague, too much of plan. But you see how correlating the clinical finding and the CT with a simple 2 different stage procedures, there has been a lot of change with him. Although he has grown and in weight, and now he's like a young adult with so much of CP and the problems, but he's very much confident and he's good to get a job or apply somewhere out in the society. So it does make a change, and you see that how the gait analysis helped us to understand how to divide the problems, how to address the big elephant. I mean, you just break it down and then you know what needs to be done. So that's it, everyone. If you all have any questions, we can take like 1 or 2. But I don't think there should be any questions. This is a very difficult topic, like I mentioned in the start. We need to have a lot of very regular seeing of charts, correlating radiologically, correlating with the videos. Then only we can give good results possibly.
Thank you, ma'am.
Thank you.
It was a very nice session.
Yes. Okay. I tried to make it very light for everyone, and if there is still any queries, feel free to message or call or talk. If you all want to do any gait analysis for your patient, that can also be done, and we can discuss the reports and we can always like work on it. Not necessary that if you don't know to do the gait, you will not get a gait report. I'm always there to help around everyone in doing a good decision making and helping with surgical planning.
Thank you so much.
Thank you.
Yeah, so thank you everyone. All of you have a nice weekend. And bye-bye.
Thank you, ma'am.
Yeah, bye-bye.